So one of the reasons I love to be the host of Scan FYI is because it gives me the opportunity to introduce everyone to all kinds of folks that we might not normally meet, or medical folks, clinicians that we don't even know that we might ever need. And today is a perfect example of that because we're going to shine a light on a thoracic surgeon. Some of you may not even know what a thoracic surgeon is, what they do, why would I ever need one? So for more information on this, stay tuned. Hey, good morning, everyone, and welcome to Scan FYI. First, I do want to say that our episode today is brought to you by Mark Vigiani of Keller Williams, Central Monmouth. So my guest today is Dr. Joseph Whitlark from Monmouth Medical, from the Barnabas Health Group, correct?
Correct.
And thank you for being with me today. I appreciate that.
Thank you for having me.
Well, the first thing I want to ask you is, why don't you just tell us a little bit about yourself?
My name is Dr. Joseph Whitlark, and I have recently joined the medical group. I'm coming from Philadelphia, where I've been practicing for several years, and I've come up as a thoracic surgeon. I'm actually a robotic oncologic surgeon, so I use robots in many different capacities, as we'll talk about today.
We'll get back to that.
But most of my focus is on cancer.
Okay.
Originally from South Carolina. I'm one of 13, the only physician, and it's a lot of different reasons, I think, that I went into thoracic surgery. I had my oldest brother died from an empyema, which is an infection in your chest, when he was 15. Had quite a big impact on our family. In fact, many years later, my mother asked me why I went into chest surgery. And I said, I found it challenging. It was very exciting. And then she said, do you think you did that because of your brother's death? And I was very small at the time, and I had to think about that because I think there may have been something to that. But about 8 years ago, my twin brother, who was a smoker, developed lung cancer. I was with him through much of that journey, where I took him up to Duke from South Carolina for his diagnosis and treatment. He had it resected. A couple of years later, came back, and he ended up passing away about 6 years ago. So it's kind of a personal thing with me, lung cancer.
Absolutely personal.
Thoracic surgery. So thoracic surgery is surgery in the chest. When we do training, we go to medical school, we do our surgical training, general surgery training, and then we do a fellowship in actually cardiothoracic surgery. So we're all trained in cardiac surgery and thoracic surgery. But in the last several years, there's been a move to specialize in just what we used to call non-cardiac thoracic surgery, but it's sort of now cardiac surgery and thoracic surgery. Thoracic surgery includes the lungs, the pericardium, the esophagus, the thymus gland, anything between your neck and your diaphragm.
That's covering a lot of territory, actually.
It is. And so we're pretty excited here. Dr. Richard Lazaro is the chief of the Southern Division here, Robert Wood Johnson, Barnabas Health. And Dr. Lazaro is a very well known. He's an excellent surgeon. And so we offer many of the same types of surgery with the robot, but so I'm excited to be here, and I think I'm excited about what the future holds for the area with this.
So what would prompt someone to have the need specifically to see a thoracic surgeon? Why do I need to see you?
Well, it's changed a little bit. It used to be that when you were worked up completely and diagnosed with a lung cancer, you were sent to a chest surgeon. And as little as 10 years ago, usually non-fellowship trained surgeons would be taking your lung out. It's general surgeons without specialized training, but that's gone away from that. Most of the vast majority of lung cancers are treated by fellowship trained thoracic surgeons. So you would be referred. it's become a bit different. In fact, one of the reasons that I have been asked to join here is because I do a special type of diagnostic procedure for lung cancer. So typically what would happen is you would get a CAT scan for a reason. You may have had a history of smoking, and your primary
Right.
care may have said, I want to do a cancer screening on you because you qualify. And then you would be found to have a nodule. And then depending on what the nodule looked like, we would make a decision about whether we would follow it with a repeat scan in a few months, or whether you would be referred for a diagnostic procedure. So a diagnostic procedure can be a CT guided biopsy with a needle. But what's been very exciting over the last 5 years or so has been robotic bronchoscopies, which I do quite a few of. So a robotic bronchoscopy is a procedure where you go to sleep, we put a tube down your throat so you don't know what's going on, and we guide a robotic bronchoscope, and we get it down to where we can get to the nodule, and we can make a diagnosis with forceps or a needle. And then you wake up and come back to the office, and we go over all the pathology. So we found it's been very, very helpful in speeding up a diagnosis of cancer, or perhaps it's non-cancer. But it's been found, especially over the last several years, that lung cancer can grow rather rapidly. So if you have a lung cancer, it's not something we want to sit on. So if the shorter we can make the time between we find your lung cancer till we treat it, the better patients do. So,
let me ask you this, because we're talking about lung cancer, and what's the prevalence of it at this point in time?
So lung cancer has actually decreased, over the last.
That's a good thing.
Good thing. Lung cancer, it has decreased, but it's still the #1 cancer killer in this country and around the world.
It is lung cancer.
And the reason for that is a couple reasons, but the main reason is because of how deadly it is. So many more prostate cancers are diagnosed, more breast cancers, and even this year, there's probably more colorectal cancers diagnosed. But that's fourth. But what happens is when we are diagnosed with lung cancer, if you wait till you have symptoms, typically you are late stage and people do very poorly.
Oh, okay.
So the cancer death of breast cancer, which is the most prevalent in women, prostate cancer, which is the most prevalent in men, and colorectal cancer, those 3 cancer deaths combined just about equal lung cancer. So it's important to understand that the 5-year survival for across the board for prostate cancer is well over 95%. Surprisingly, people would be surprised to know that the overall survival rate for breast cancer is over 90%. Colorectal carcinoma is about 65 to 70%. So that's once you get to 5 years, you may not necessarily be cured, but your incidence of developing recurrence will go way down. So one of the biggest weapons we have in fighting lung cancer is to diagnose it early. So if we can diagnose it early, we can get the rate up to above 70, and in a very early stage of lung cancers, we can get a 90% survival rate. We go down to a stage 2 with it in the lymph nodes, it's going to drop to 50 to 60%. If we drop down to what's called the stage 3, where it's beyond the lung, that's a 20 to 40%. And the survival for a stage 4 is under 10%. So unfortunately, in the United States, which is very advanced in diagnostic capabilities for diagnosing lung cancer, we still diagnose the vast majority after stage 2.
So, is that because you probably don't have symptoms that are worthy of even mentioning? What would a person even be looking for?
Well, like I said, if we wait till you're symptomatic, typically you're late stage.
Right,
so
exactly.
That is why there's been a push for screening CT scans of chest. So even if you've quit smoking, if years ago, you may still be a candidate for a screening CT. That's only been approved over the last 10 years, actually, and it's just expanded a couple of years ago by the preventative task force, the U.S. Preventative Task Force. So now, so for breast cancer, mammograms are regularly ordered by your primary care physician. Everybody knows they're going to get a colonoscopy. They should get a colonoscopy at age 45 or 50, and the primary care physicians push that. Prostate cancers used to be screened with prostate-specific antigen testing. That there was an overdiagnosis, so that was decreased. Although there's still some probably some merit to doing that in people that are risk that have high family histories and stuff. So for those cancers, you have screening that's regularly ordered, and we all know about it. We all know you're going to get you need to get your colonoscopy. You have to get your mammogram, and but for lung cancer, it's relatively new, the screening, and the screening has had some controversy over the last several decades. It's only been in the last 10 years or so that there's been an agreement that a consensus that screening scans are helpful. And quite frankly, where we find our early stage lung cancers are usually serendipitously ordered CT scans. Someone comes to the CAT scan, to the emergency room and gets a CAT scan to make sure they don't have a blood clot to their lung, or they come in with flank pain and it may be a kidney stone, and when they do the scan, they get the lower part of the lung. Or if someone has a problem with their neck and they get a CT scan, it may get the upper parts of their lungs. We call those incidental nodules, and that is probably the number one reason, the number one way that we discover lung cancer.
But that's kind of accidentally. Yeah.
So there's been a push, and I think, and I have seen in the last 10 years that since the primary care physicians will be the ones that will be driving this, but every year it becomes better where they that's part of their screening. And when that becomes more widespread, I think you're going to see when it becomes as widespread as, you have to get your colonoscopy, you have to get your mammogram. People don't argue about that because it's so ingrained in us, not only in the American public, but primary care physicians. So
Dr. Whitlark, who would be a good candidate to get a screening for lung cancer? People who are listening, I'm thinking, so who should speak about this with their primary physician?
So that has just been expanded. It's estimated there's about 13 million people that are candidates for lung screening in this country. It was just expanded. The age dropped from 55 to 50, and a history of cigarette smoking. Typically, they would like to have you have quit shorter than 15 years ago. And sometimes the amount, it used to be 20 pack years. 20 pack years is a pack of cigarettes a day for 20 years. They dropped that to 15. So that expanded. You drop the age and drop the amount, the time. The amount that's smoking. It has really expanded the pool of people who are eligible. And when we talk about eligible, if you can't just go to your primary care doctor and say, order a CAT scan on me of your chest. Not only is it expensive, but there's a significant amount of radiation involved in that. Screening CTs are specifically called low-dose screening CT scans. We're not looking for very subtle findings. We're looking for a nodule or something that has no symptoms that we then determine, and it's multiple people determining what needs to be done with that nodule, which is why the robotic bronchoscopes are so, it's been such a great thing for diagnosing and then subsequently treating these patients. So we've been excited about that.
Would you come back to the whole idea of robotic surgery? Because again, people listening, we hear the expression robotic surgery. You are actually the surgeon, but explain how that works, if you would.
So it's important to understand in my career, when I trained and when I learned, there were no scopes, there were no robots. We would open people's chest the way we did for 60 years. That's a very painful operation. And
talk about invasive.
Right, maximally invasive, exactly right. But then 20 plus years ago, thoracoscopic surgery became it became in vogue. It was small incisions in your side, and most of us trained on that. I did many cases thoracoscopically, and the robot just takes it a step further. There has been some controversy about whether it's actually an improvement but I think that the data is coming out now, which shows that it is an improvement over thoracoscopic surgery, although some people will argue that. And at our national meetings, they argue it fairly vehemently. But so what happens with a robotic lung resection is we put small holes called trocars, small tubes in your chest, 4 or 5 small incisions in your side, whatever side the cancer's on, and we put a scope in, and we put instruments. So the robot doesn't do anything; it just does what my hands do.
Right, you're still the surgeon, yes.
Right. So what happens is it greatly helps us because the scope magnifies everything 10 times, and actually the scope has 2 small cameras on the end of it, so we actually see in 3D, which is amazing. The thoracoscopic scopes do not do that. And then we have staplers and we have other things. So we can remove a portion of your lung that has a cancer and remove all the lymph nodes. And you have 4 small incisions that usually don't have sutures in them. Sutures are inside the skin. And then after 3 days or so, you take your dressings off when you get home and you take a shower and go about your business. Now, there's still some pain, but not nearly the amount of pain and length of hospitalization, complication, open surgery. And we do all kinds of robotic surgeries. We remove cancer of the esophagus with a robot. We remove cancer of the thymus with a robot. We do a tremendous amount with the robot. Almost everything you can do open.
Well, I just think it's remarkable that years ago, people had their chests cracked open, basically. And I know people that have had that done. And of course, that was because this option was not, who could have imagined? But
exactly.
It is remarkable, the advances. It really is.
I actually have a personal story about that. Is my mother, who never smoked, developed a lung nodule. And she was about 80, and I was a surgeon at the time, but she was living in South Carolina. I was working in Philadelphia, and I browbeat the surgeons into removing it. And it was a cancer, and they opened her chest to do it. And she was cured, actually. She died several years later from a stroke. But she was mad at me for 6 months because it really hurt her. And she was in the hospital for a couple of weeks, and it really, really hurt. So after about 6 months, she forgave me. But it was if you fast forward 20 years later, when my brother had his surgery, he was out of the hospital in 3 days. He had small incisions, and he was back to work within 3 weeks or so, which was remarkable. So it's sort of
is there even a need these days to crack open somebody? That expression is horrifying too. But to open someone's chest, is that a fairly?
There's still it's become very rare, but it's still required in different types of cancers. It's still required, but it's become much more rare. Even in cardiac surgery, for certain valve repairs, replacements, or certain phases of coronary artery disease, you can do it robotically. So not opening the chest is still a big deal.
All right. Well, if you're listening out there, I think now you understand a little bit more about what does a thoracic surgeon actually do. I mean, hopefully we won't need you on a professional level, Dr. Whitlark, but you know what? It's good to know that you're out there. Good to know. I appreciate I really appreciate your being with me today and really explaining there's a lot of new things apparently on the horizon.
There's a lot of new things. In fact, one of the reasons I'm here is we have a new technology, and I think we're going to be the first in New Jersey to use this. And it's we call that pulsed electrical field therapy, and we can actually do it when we do our robotic bronchoscopies. I started this when I was down in Philadelphia, and we are bringing that technology to New Jersey, and we're pretty excited about it. We've had some tremendous responses. It's not surgery, and it's not radiation or chemotherapy, and so it's brand new, and it's not for everybody, but we've seen some remarkable results. So we're very, very excited about that too.
What is that used for?
These all kinds of cancers. We will be using it for lung cancer primarily, but it's been used for, I've had some tremendous results with some sarcomas, breast cancers, other types of cancers. Very exciting. but it's in its infancy. So we really don't have, we don't know. We're learning what the applications are, but the best thing about it, it has so few side effects. And we've had some remarkable responses to it.
Well, all right. So you heard it here first. Excellent. Okay, that's really, I'm very appreciative of you being with me today. And I feel like you gave us a lot of good information. Sometimes I think people listening think, well, I don't need a thoracic surgeon. Well, maybe today you don't, but we don't know what the future holds. And my whole purpose here is sharing information for the community. So you never know what the future holds. Maybe you or a loved one might need a thoracic surgeon, and here you go. I've just introduced you to one.
Andrew, thank you very much.
You're welcome. And we will put all of Dr. Whitlark's contact information in the comments if anyone needs to reach out to his office. So once again, thank you so much for being my guest today.
Thank you.
Okay. Remember out there, if it's important to you, it's important to us. I'm Andrea Tarr, and we'll see you next time on Scan FYI. Bye, everyone, and bye, Dr. Whitlark.